Hi everyone, I'm Dr. Tucker, and today we're going to talk about what comprises an audiological evaluation or an audio test. The type of patients we like to test, anyone from age 4 to 104 is what I like to say. Whenever we have a patient come in, we first want to obtain a lengthy case history, which is essentially a conversation that we have with the patient. Do they have a family history of hearing loss? Have they had any loud noise exposures in their lives? Have they had any ear surgeries that we should know about? Any perforated eardrums? Are they experiencing pain in the ears? Any ringing in the ears? Do they feel like the room is spinning, or what we sometimes call vertigo? These are all basic things we want to find out. Even if a patient claims that they don't have hearing loss, which we do hear a lot, I would ask something like, do they feel like one ear hears better than the other? Because sometimes, even if you're hearing okay, one ear is doing more of the heavy lifting than the other. These are all things we like to find out before we get them into the test. Then we go ahead and take a look in their ears, what we call an otoscopic evaluation or otoscopy. We note the landmarks of the eardrum, if there's any wax, any fluid, drainage. We assess a basic visual inspection of the eardrum as well. We have a battery of tests. The first thing that we do doesn't involve the patient to do anything but just hang out there and let it happen. It's called otoacoustic emissions, also known as OAEs. Otoacoustic emissions are something that happens all the time. Right now, as we're having this conversation, my inner ear, the outer hair cells of my inner ear, are producing slight tones that are escaping out to my middle ear space, but no one can hear those tones. During this first part of the audio exam, the patient's just sitting there quietly, hearing some tones, but what we're doing is we're watching the two tones that we send in to the ear. We're essentially recording the one distortion product that comes back out. The next test after OAEs is we actually run an emittance battery, which is tympanometry and acoustic reflexes. Tympanometry is essentially the study of the eardrum. What we're doing is we send a pressure wave from positive to negative pressure, and we show how the eardrum is moving along that wave. And so the patient is sitting there quietly. They might experience a puff of air similar to being on an airplane. But while that's happening, we're recording how their eardrum is moving. After tympanometry, really it's part of that same test, we present loud tones to assess the acoustic reflex pathway. So it's kind of interesting. This is an involuntary thing that happens. When we hear loud noises, like at a concert, our acoustic reflex involuntarily occurs, which simultaneously retreats our stapes, which is our third and final hearing bone, away from the cochlea a bit, and that's due to our stapedial muscle, and it flexes our tensor tympani. Our tensor tympani muscle runs along the eardrum, and when it flexes, our eardrum tightens up. So essentially, we have a natural defense towards loud sounds. But when we're in the test booth, I'm actually trying to elicit that to see if the reflexes are intact at 4 different tones, at 500, 1K, 2K, and 4K hertz.
Brief sensation of pressure in your ear. The pressure will come on, and then it will release, and then you'll start to hear intermittent tones that will get louder and louder, but you don't have to do anything. You can just relax from this part. Are you ready?
During this time, as the patient, you might be just sitting there quietly hearing some loud tones, but it's only for a short amount of time, and there's nothing you need to do because, again, we're testing this involuntary, naturally occurring reflex. We go into our standard hearing test. What we do normally is we use insert earphones. Sometimes we use over-the-ear headphones. And we put in the insert earphones deep into the canal, and we instruct the patient. The first thing we do is called the speech reception threshold, or SRTs. We try to play bisyllabic words like ear horn or baseball or sidewalk to give our patients a chance to repeat those words. And we're trying to find out what is the softest level where they can repeat those words successfully at least 50% of the time. Then we move on to our classic pure tone testing. So pure tone testing is when we have the patient listen to various beeps across the speech spectrum, all the way down from 250 hertz, which is a very low, bassy tone, up to 8,000 hertz, which is a very high-pitched treble tone. And what we're assessing is what is the softest level that they can hear that tone at least 50% of the time correctly. That's what we mark as a threshold. We do the threshold for air conduction, which is through the headphones or the over-the-ear muffs, and then we also do the same through bone conduction. Not a lot of people know this, but when we stimulate the bone directly, we're actually bypassing the eardrum, the middle ear space, the malleus incus stapes, and we're directly going straight to the cochlea. So for someone that might have an ear infection, to have that difference of when we test via air and bone is crucial information to then give to the ear, nose, throat doctor. Bone conduction hearing, as opposed to air conduction hearing, is when we put a stimulator, it's called a bone oscillator, right on the mastoid process of the temporal bone, and we are able to stimulate the bone directly. What that does is we skip the ear canal, we skip past the eardrum, the malleus incus stapes, and through bone, we're able to stimulate the cochlea, our hearing organ, directly. We leave the headphones in, and then we do word recognition scores. The purpose of word recognition scores, as opposed to speech reception threshold, where we're trying to find the softest, is with word recognition, we're often trying to find the most comfortable level for the patient to repeat words back successfully. So we might try them at different volumes, but essentially we're trying to make the patient at their comfortable listening level and have them repeat words. While you're actively participating as the patient, there may be a time where your audio tester or audiologist is going to play some noise to block out your non-test ear. For example, if the bone oscillator is on your right side, we might need to put an insert headphone and play some wind noise to block out the left side so we can focus on what your right side is really doing. We'll always tell you what to expect, but oftentimes it sounds just like a wind noise or a static. We're going to quickly show you a very brief overview of what we did, but the real value is when we take all of this information, the case history, the otoscopy, the tympanometry and acoustic reflexes testing, the speech reception threshold, the air conduction, the bone conduction, and the word recognition scoring. When we put all of those tests together into a formal report, that is when we get the true value of our audiological evaluation or our audiogram. When that report is done, we send it over to the primary care doctor that referred you and or your ear, nose, throat doctor, who can then review it with you in more detail.